Hello everybody, welcome to the education component of our project on community-based youth concussion management. We are a group from ATSU SOMA in Arizona. I'm Aaron Allgood, internal medicine physician.
And I'm Tamara McLeod, athletic training program director.
And we are going to take you through some steps today about concussion and concussion management, and we appreciate all of your support.
So our goals for this webinar are to provide you with the top 10 things to know about sport-related concussion. This will include some updated information about the definition and etiology, signs and symptoms, assessment, misconceptions about imaging, and appropriate steps in managing the patient to get them back to return to learn and return to play. We'll finish off talking about some myths about prevention of concussion, as well as important information about your state law.
So what is a concussion? And this is the simplified version of this, a complex pathophysiological process affecting the brain induced by mild mechanical forces. To dive deeper into this could be caused by several different things, mostly an impulsive force that's transmitted to the head. So it could be a direct blow to the head, but the force is really what we're talking about a little bit more here. This typically results in rapid onset of an impairment of some sort of neurological function that usually resolves spontaneously, but in some cases can evolve over a number of minutes to hours. This can result in neuropathological changes, and these can produce acute symptoms that mainly reflect functional disturbance of the individual and rather than structural injury. And we'll talk a lot about that as we go, as there's usually no abnormality seen on our standard structural neuroimaging studies like CT and MRI. So this results in a graded set of clinical symptoms across several different domains that may or may not involve consciousness. And then as we manage this concussions, this results in the resolution of these clinical and cognitive symptoms that follow a set course. In some cases, these symptoms can be prolonged.
And in this video, you will be seeing a hockey athlete in a typical mechanism that may result in a concussion. As they're skating along the boards, they're hit by another individual. And while that initial hit may not always be to the head, the impulsive force of the hit from one player to the other and from the player being hit to the boards causes an impulsive force that can transmit to the head. This results in shaking in the brain, and the word concussion means to shake. It's this shaking in the brain that causes this functional disturbance that we often associate with concussion. There is no structural injury, no bleeding in the brain, and I think it's important to note in this video that the athlete was wearing a helmet, and as we'll talk later, helmets are not always preventative of concussion. So the next question is, who suffers from concussions? Athletes in a number of different sports, as well as our military providers and individuals who participate in recreational activities, can all suffer concussions. Current estimates regarding the epidemiology of sport-related concussion do note that there's little data in patients under high school age. We do know that there are more than 44 million youth who participate in sports annually, and it's estimated that somewhere between 1.1 and 1.9 million concussions result from sport and recreational related activities. While a smaller number of these do report to the emergency department for their injury, it is individuals who do not seek health care that is important to note, as well as those that you may see in the community health centers and other outpatient settings.
So what are the symptoms of concussion? This is not just one symptom that we're looking for. We're looking for several different areas of symptoms that can stem from cognitive, sleep and energy, physical, and emotional. And as you could see, there's 4 different areas of symptoms that a person could be experiencing and you will be evaluating.
So that gets into how concussions are assessed.
The concussion assessment stems from preclinical, before the actual concussion happens, to clinical, what's happening on the field and in the ER, and then beyond, in the clinics, the schools, and beyond. And to do that, you have to take several different areas of assessment: clinical exam, symptoms, postural control, vestibular, ocular, mental status, and neurocognitive. They've all come into play with your assessment.
And that's important to note because the concussion assessment does occur on a timeline with certain data collected at baseline or before an injury even happens. It is becoming more commonplace that things like neurocognitive and balance testing are done in this baseline mode. We may also want to get a good understanding of the patient's normal symptoms. For example, if a patient has migraine symptoms quite regularly, that would be important to note on a post-injury exam. The pre-participation physical exam gives the clinician the ability to determine past medical history, past concussion history, as well as other comorbid factors such as learning disabilities and attention deficit hyperactivity disorder that may place the individual at greater risk for concussion or a prolonged recovery. At the time of the injury, the on-field or sideline assessment is critical. This is where the clinician determines the concussion diagnosis, would remove the individual from play, and monitors red flags for immediate referral to the emergency department. During this time, it is also important to evaluate in a serial manner to determine if the patient is deteriorating in any of those areas related to the red flags. Lastly, the follow-up or subsequent exams would happen within the first 24 hours after the injury and at sequential time points over the course of recovery. The follow-up exam can include the same tests as administered at baseline to determine the initial deficits following concussion, as well as the individual's recovery trajectory. The use of these adjunct assessment tools also aids in determining recovery as well as the progression to both return to learn and return to play protocols. Proper assessment begins with the pre-participation exam, and the question up on this screen is one that's used in the International Olympic Committee's evaluation of elite athletes. The question allows the clinician to ask the patient about prior injuries to numerous body parts that could be related to concussion, includes symptoms such as confusion, memory loss, or headache, and includes lay terms such as bell rung or getting dinged that sometimes athletes do not associate with concussion. It's important to have a good understanding of prior concussion history because a concussion history can increase the individual's risk of sustaining another concussion. The proper assessment also includes a thorough clinical and neurologic examination, use of the adjunct assessment tools in the baseline and follow-up paradigm, as well as appropriate follow-up and return to play progressions. This table presents some of the types of concussion assessments that are often used by athletic trainers and those working with sports medicine on a regular basis. Prior to the sports season, things such as the prior concussion history, concussion-related personal history, and family history are important components of the pre-participation exam. At the time of injury, the clinician should evaluate for symptoms using standardized symptom checklists or scales, mental status using something like the standardized assessment of concussion, a mini mental status exam, or even just remembering 3 words or reciting digits in reverse order. The eye exam, muscle strength, and motor control can all be done as part of the clinical exam or using concussion-specific balance assessments such as the balance error scoring system. Neurocognitive assessments are often done during the follow-up protocol to assist the clinician in making decisions about when it is safe to return to play.
So acute concussion evaluation, sometimes it's not so obvious if somebody has a concussion. It's important to remember that not all people that have concussions lose consciousness. Therefore, you have to go through all of your different clinical domains and look for these symptoms of our athletes and children. Remember, when in doubt, take them out. So if you have any of these symptoms, make sure that you take them off the field of play. And for our providers that see them after this in the emergency room or urgent care, the instructions that you need to be given are mainly about education, instructions for physical and cognitive rest. Of course, you are looking for red flags, your neurologic symptoms, your reasons to order CT, MRI, those types of things. You have to rule out a more serious injury, there's no doubt. But beyond that, you must know that good education on instructions to rest and not to clear them to return to learn or play immediately until they can have that follow-up with a primary care physician or athletic trainer for continued evaluation.
With respect to neurocognitive testing, most sports teams and academic institutions are now using some type of computerized neurocognitive assessment. The 4 up here are the common ones that are used, with impact probably being used most frequently by sports teams. All of these provide additional information about cognitive function and can be a vital part of the concussion management plan.
And it's important to know that there are times to refer to specialists. So for prolonged symptoms, sleep disturbances, for example, a neurologist would be consulted. And so this usually comes after that initial assessment when they have lingering symptoms that do not resolve.
A neuropsychologist and vestibular therapist can also be used as part of the treatment paradigm in individuals who may be having cognitive deficits or school issues, or those specifically endorsing dizziness and balance problems. One misconception that we often see with sports concussion is how useful is imaging, and in some cases, the over-reliance on imaging for this particular injury. While neuroimaging can be important to rule out intracranial hemorrhage, and it is a key factor in monitoring for red flags in the emergency department, CTs and MRIs have little value in assessing less severe injuries such as concussion. With concussion being a functional injury, there is not structural damage to the brain that would be noted on either of these modalities. CT should not be used to diagnose concussion, and neither of these have any use in contributing to determining when an individual has recovered or is ready to return to activity. Interestingly, CT scans in the emergency department has been identified as one of the top 5 procedures that should not be ordered regularly for mild traumatic brain injury. We need to be concerned with radiation and younger athletes, and in many cases, we can evaluate and monitor these injuries without additional imaging.
Now, it is important to remember that neuroimaging does have its place, and when doing so, when the symptoms occur, you need to rule out intracranial pathology. This is a list of variables that could predict intracranial pathology bleeding in pediatric patients. There are different guidelines and different lists out there to look for possible intracranial bleeding, so please be aware that that can occur, and there is a place for CT if you are concerned about intracranial bleeding.
So now we get into how concussions are managed. And historically, it's been through rest, both physical rest and cognitive rest. Physical rest can include removal from sport activity and limiting participation in physical education classes. Cognitive rest, on the other hand, deals with limiting brain activity, mental activity that can result in excessive thought, such as reading, significant computer use, listening to loud music, and other distracting types of activities. The concussion management team includes a number of different individuals who can help to both facilitate physical and cognitive rest. Starting in the top left corner, the school-affiliated healthcare personnel can include the athletic trainer and the school nurse if they are available at the school or team physician, mental health counselors and school psychologists, as well as school therapists. These individuals are more likely to see the patient on a regular basis, including daily patient encounters, and will allow for the administration of additional assessment tools and communication with the primary care providers. The school personnel includes administrators, counselors, teachers, and coaches who can help to administer any academic adjustments and ensure that cognitive rest is available to the patient. What the family does at home is critical. Parents and patients themselves need to understand the limitations that are placed on them with physical and cognitive rest, including the individual's peers and friends who should be supportive during the recovery process. Outside medical professionals, such as the primary care provider, emergency department physicians, concussion specialists, and other important medical referrals, are also key components of the concussion management team. The take-home point is that concussion cannot be managed by one provider alone and does need to include a comprehensive interdisciplinary management team. The roles of the outside medical professionals include ruling out more serious injury, evaluating the patient periodically, coordinating information from other team members, and encouragement of physical and cognitive rest. The school-affiliated providers assist to watch and monitor and track symptoms on a daily basis, ensure that no physical activity occurs, and provide information about how symptoms fluctuate over the course of a school day to other medical providers. The school personnel should be supportive in reducing cognitive load, implementing academic adjustments, and tracking academic and emotional issues throughout the course of recovery. Lastly, the family should impose rest, monitor and track symptoms at home, evaluate and be on the lookout for emotional and sleep-related problems, and communicate information with school teams. The key here is that all of these groups need to be in constant communication with each other to ensure successful recovery of the patient.
So when should an individual return to activity following concussion? The key statement here is return to activity, and it starts with rest, cognitive and physical rest. These need to occur both at the same time. However, we need to concentrate on the return to learn portion before we can return to play.
However, oftentimes people have focused on the return to play before the return to learn. It's critical that we ensure that our student athletes return safely to a classroom before we begin a return to play progression. In order to help facilitate your work with patients following concussion, we've developed the ATSU Concussion Toolkit. This includes information sheets, sample correspondence letters, and other information for providers, patients, and families. This initial chart is part of the toolkit and discusses the physical, emotional, cognitive, and sleep symptoms that we might encounter in a patient after concussion, in addition to providing suggested academic adjustments that could be initiated depending on the patient's symptoms and clinical presentation.
The toolkit also has sample letters that spell out everything that you want the school to know about your patient and the plan that is ahead of them. So this is an academic sample letter, and as you can see, you can just put in their name and when the date of the concussion occurred. Now remember, recovery time is individualized and it varies, which is why you can't return them to play at a certain time without going through the progression. So the other thing about this is that they should not return to sports or physical education before you could get them to school to do their schoolwork and return to learn without symptoms. After this, there is a checklist that you can use to make those academic adjustments that can help your patient go through their day. For example, if you think they need sunglasses, you can check this along with your letter, and a quiet room for the teacher and school personnel so that they can ensure that your patient is getting what they need in the classroom.
Now, the Return to Learn protocol is a staged approach that begins with the patient resting at home. Their activity level should be low, and specific criteria have been provided that would allow you to recommend your patient to move to the next stage. These first 3 stages here get them back to a full day of academics at school with some academic adjustments. Continuing on, we can get them to a full day with minimal supports, and then finally a full day where they are engaged in the classroom without additional rest or academic adjustments. It is important to note that when they complete the 5th stage of the Return to Learn protocol, they are ready to begin the return to play progression.
So when should an individual return to play following concussion? Well, this progression, as Tamara just told you, begins when the patient is asymptomatic. Okay, that's asymptomatic, off medications, and able to do their full schoolwork. They also would have returned to baseline neurocognitive and balance assessments and back to their baseline on a full neurological exam. This is part of the toolkit that is offered from ATSU that goes through each stage of the return to play.
So this starts off with no activity and then begins to get the patient into light aerobic activity. With this, we want to see if just doing additional activity and having an increased heart rate brings symptoms back. If it does, we want to continue to rest and wait before we begin the progression. If the athlete can tolerate light aerobic activity, we then want to bring them through sport-specific exercise and non-contact training drills before a full contact practice. It is important to note that we recommend in our toolkit that on successful completion of non-contact training drills, that the patient obtains written medical clearance from a healthcare provider recognized by your state law before starting a full contact practice. Once they can make it through a full contact practice, the individual can be cleared for game play.
And this is a sample of the corresponding letter that you could fill out for your patient, for school personnel, as your patient progresses through these stages. On this letter, you will have their name, the fact that they have returned full-time to their school work without symptoms, and that their assessed neurocognitive, balance, and ocular function have all returned to baseline levels. You will then be able to indicate what stage that they will start from, and then they can start on the return to play protocol. Then, once they progress through 1 to 4, they come back to see the provider to get the return to full contact practice. On this sample letter that you can provide to the school, you can make check marks into the patient that will no longer need any continued academic adjustments and that they have successfully completed steps 1 through 4 of the return to activity protocol, and again that all of their neurocognitive, balance, and ocular motion function have returned to baseline.
Now we want to discuss whether or not we can prevent concussions. You'll notice in this football video that as the football player is hit, the head still shakes inside the helmeted skull, It is important to note that while some people think that helmets and other protective equipment may prevent concussion, that is not always the case, and the brain still has the ability to move inside the skull that results in slowing of the messages and transmission of those messages that results in the functional disturbances that we see with concussion.
So as you know, in medicine, when we talk about primary prevention of disease, we are talking about preventing a development of disease or injury in healthy people. We do the same for concussion research and management, where we're looking at these different angles on primary prevention, legislation, rule changes, behavioral modification, protective equipment, and prevention interventions, and what we could do to help primary prevention. There is also secondary prevention, which is just as important. These are patients that have the illness or have the injury, and what we can do to prevent another one.
Now, while there isn't great evidence for some areas of prevention for concussion, and it's often hard to prevent that first concussion from happening, some have looked at equipment as a potential means of preventing concussion. Unfortunately, the evidence to date has identified that helmets, helmet covers, headbands, mouth guards, and face shields will not necessarily prevent concussion. Helmets are intended to prevent skull fracture and other injury. The only areas where they have been shown to be beneficial is in high-velocity sports, such as alpine snow sports and bicycling. The other types of equipment have limited protective ability as they are currently developed in the modes that they currently exist. Looking at our primary prevention scorecard, not all areas have been shown to be beneficial in preventing concussion. It's questionable as to whether or not legislation is useful in preventing concussion. Only one state to date has had their law in place long enough and has actually studied it post-concussion. While they have noted that the education about concussion has increased since the institution of the law, whether or not it has actually decreased concussion rates is unknown. Rule changes and behavioral modification are currently the most beneficial way to prevent concussion. Rule changes such as establishing body checking at older age groups, changing the kickoff in football, and behavioral modifications such as helmetless tackling and appropriate tackling using something like the Heads Up program have been shown to reduce concussion rates. Protective equipment in the current state that they have been developed is not protective or preventative for concussion. And we have not studied interventions such as neck strengthening or vision training enough to warrant them as preventative measures, but they do hold promise and should be evaluated further. On the other hand, we have good data on several areas where we know we can prevent second concussions, second impact syndrome, or returning athletes to play too early. Improving concussion reporting allows the individual to be removed from play and evaluated by a healthcare provider. Proper assessment, including the use of adjunct assessment tools, is beneficial in not letting patients or athletes return to play too early. An appropriate management that includes the interdisciplinary management team and the use of experts in various areas has been found to be beneficial in ensuring that the athlete returns to participation, both school and sports, in a safe manner. Anticipatory guidance is an area where we are currently still investigating its usefulness. But with anticipatory guidance, it's providing education to the patient about what to expect during the recovery process to try and limit their anxiety and concerns about recovery and provide them with a roadmap that may be beneficial into what to expect during the recovery process.
Now, what are the state laws on concussion management? Now, as Tamara just said, back in May of 2009, the state of Washington was the first to pass a law on return to play. Since Washington has made this a law, all 50 states have followed suit, and they all now have return to play laws. There are three main tenets of each of these state concussion legislations. The first one would be to mandate educational outreach to coaches, parents, and athletes. The next one would be the immediate removal of play of any athlete that sustains a concussion or that you suspect has sustained a concussion. And the last one would to allow those athletes that exhibit these signs and symptoms and behavior to return to physical activity after receiving that written clearance from a healthcare provider. The toolkit that we spelled out hopefully can help you follow these tenets. Every state concussion law requires education, and for whom would vary. So it behooves you to look at your own state law to make sure that you are in compliance.
In addition, every state interscholastic athletic association also requires some type of education. The requirements for this education may be more strict than your state law, and they may spell out specific programs such as the Center for Disease Control's Concussion Web Training or the National Federation for State High Schools Training. For individuals at the high school level, it is important to understand what additional policies are in place from the Interscholastic Association that may be above and beyond the state law.
For more information on your specific state law and anything that we have covered in our concussion education program, please visit www.atsuconcussion.com. In conclusion, we'd like to thank all of our members of our interdisciplinary research team, which includes Dr. Lewis, Dr. Bacon, Ms. Boyle, Ms. Wheelahan, and Dr. Navarro. We would also like to thank all of our partners across the country in South Carolina, Washington, and Illinois for all of your support as we deliver our concussion education across our community health centers. Thank you.